Olihe Okoro is faculty and researcher at the University of Minnesota College of Pharmacy, Duluth. Her research focuses on health disparities affecting minority and underserved populations. More specifically, her work emphasizes the importance of cultural, socioeconomic, provider-associated, and system-related factors in health and in healthcare. This presenter has indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and/or investigational uses of any product or services and will not include trade names. Dr. Okoro, the floor is yours.
Thank you, Amy. Glad to be here with all of you. I know you have been having a good time at the conference, even though it's virtual. And so I'm glad to be with us here. I'm a storyteller, so I will try to keep within the allotted time. I am not coming at you with any data necessarily. I hope to keep this really conversational and share some experiences with us. So as you can see from my the title, it is racism as a public health problem. But I do have a subtitle there, an outsider-insider perspective. In the couple of minutes that I have been speaking, you probably have picked up on my accent. So I am not originally from the US, and I spent my adult years, back in my home country. And I don't know if anybody could have guessed that, maybe from my name, who knows? I don't know if there are any persons who are familiar with African countries. Well, I am, I hope this is going to advance, okay? I'm from Nigeria, okay? And so talking about race has just been, or being engaged in the work that I do with health disparities has been very interesting because I came from a country where the concept of race, if at all it exists, is quite different. I didn't really have a concept of race, let me just put it that way, because of the close to 200 million people in Nigeria, every Nigerian is Black. And so there was really no concept of race. So I'm coming at this from that perspective and just, an observer who has become a participant, in the daily life here and part of the society in the US. So let's get started. This is public health we're talking about. And so the key thing is the differences that we see, the health disparities that we see, both in terms of healthcare status, healthcare delivery, and outcomes. And so the race-associated differences, we continue to see them. They're routinely documented. I'm a researcher, and every time that one wants to do a survey or you're looking at any data, even secondary data, one of the things that come to mind is race ethnicity, because you want to collect that data. So it's routinely documented. And of course, when we see study findings, I actually went to PubMed and I typed in, keywords, search words, race and disparities and health. And I got like approximately 23,000 hits. So it's clearly demonstrated there are differences based on racial categories. But what you don't see as much, so we see that in data all the time. What we don't usually see as much is the explanation. And so people can see those differences, but what do they actually mean? How do they come about? A lot of times, in terms of data collection and in our data analysis, we often treat race ethnicity as confounding and even as a causal factor. And so you begin to see things like, the predictors for some outcome, and then race could be one of them. And so we see those things, but they're not adequately explained. So let's talk about race. So I know that, I can't see your faces. I don't exactly know who's here. I wish we had been in person. So I look forward to next year. Hopefully, who knows, maybe I'll be able to attend next year. I like to talk to people. I like to see people. I know that talking about race can be uncomfortable, but it is a discomfort that we really need to just embrace, because if we don't talk about it, we're not going to deal with the issues that arise because of race. So let's look at a very simple definition. What is race? Race is it's a categorization. And so, of course, every time we see race, we see categories, right? It's a categorization of people. But the issue is what informed those categories? Because we have to pull back and look at that. It's a categorization of people that is based on shared inherited physical characteristics like the skin color, like facial features, the body build, hair, and things like that. So that's that categorization. But who made that categorization and what was it really based on? So we'll talk a little bit more. Sorry, that's my phone falling off. A little bit more about that. I'm going to show you this picture. So what we're talking about categorization. What do you notice about this? I wasn't sure what platform we were going to use. I had hopes to, engage us a little bit and have some feedback from you. I don't know if that's going to work. Am I able to see the chat? What strikes you about this, this group of people here? What do they have in common? So I'll just pause and just have you reflect. Obviously they are all, celebrities. A couple of them have passed on. So a couple of them are of blessed memory. But one thing they do have in common, if you're someone who watches TV and movies and all of that, is that they're all actors and actresses. What else about this group of people? Well, all of them here in the US are considered Black. So going by the definition that we have given prior, which is a categorization that is based on this physical features and attributes that people have. Looking at this group of people, how do we even make that determination? Are there physical characteristics that we're seeing that makes all of them the same people or the same, from the same group based on race, ethnicity? So you see that categorization, it doesn't really hold up because you have so much more going on and so many nuances. And I would say also from the perspective of someone who grew up elsewhere, this group of people in Nigeria, they will not all be considered Black. Megan, for instance, will be considered white because in my country, our concept of identity is actually based on a patriarchal system. So you are from wherever your father is from, regardless of where your mom is from. So that's also another concept that you would see, that when it comes to race, it depends on where you are. It depends on who came up with that and what exactly are they using to categorize. So we see that based on that, race truly is a social construct. It's an ideology that is not objective in terms of its reality. Of course, there are physical differences. As you look at me as I'm presenting, I'm Black. That's obvious. And of course, the hue of my skin has something to do, with my genetics. All right. So it's something that you can see. But what should we, because of that, consider it a biological construct? Are we saying that these attributes that we see physically are based on innate traits that then determine something or the other? So race basically, just like we would, attribute the value we have attributed to notes, for instance, or to the credit card, that when you use it, it's what we as a society have agreed on. And that's what makes it what it is. And so that is how race is. It really is socially constructed. And sociologists have also shown, especially in terms of the Western world, race categories were based on stratifications that had to do with power. So these stratifications really, at the time that people were being categorized, put people in different categories based on worth, in quotes. And it created a system that made one group superior to another group, and so on and so forth. And that's actually how it came about. And we have to come to terms with that. And then we have to look at how has that then caused problems to this time, and what can we do to address that? Because we're seeing it all the time in health, in healthcare delivery, and we're seeing it in health outcomes. So let's talk about race-associated health disparities, because based on the concept of race, whether we consider it a social construct or we consider it a biological construct, that will then determine how we perceive health disparities and how we address them, how we explain them, and the interventions that we put in place to address those. So race-associated health disparities, we know that those exist. We see them all the time. Are they because of inherent genetic differences? Because sometimes some of the data that we see and some of the findings that we see, especially some of us that are in research and in the scholarly arena, some of them tend to posture health disparities really more as something inherent. And we see that even in treatment, the way we have some of the treatment guidelines that we have that are based on race, what we call race-based medicine. They posture, health disparities and the differences that we see as being inherently genetic. But the case that, I am bringing forth to us this morning and I want us to consider is race-associated health disparities. Is it attributed to social policies and structures that we have in place? So let's look at racism. Racism, so I was looking, I have drawn, a lot of my knowledge around this from Camara Jones' work. She's done a lot of work in this area. And so let's look at what racism is. So you have racism at three levels. And I want to bring this up for us to consider so that we can really see the interplay of some of these things and how it results in the public health crisis that we continue to have that are along racial ethnic lines. So you have institutionalized racism. There is the individually and personally mediated racism. That is the one-on-one that people experience. And when we say racism, that's what people by default think about. And then you have the internalized racism. So let's talk about a couple of the features, around some of this. I have to scroll this a little bit. I don't know if it's, okay. So let's look at institutionalized racism and just a few of the features. So first of all, it is something that, of course, started off, first of all, based on just the initial categorization differences that people had, the initial historical traumas that different groups have experienced because of the categorization as a group of people. And so I will use a lot of examples from the Black and African American population, because that's what I'm most familiar with. So you look at something like slavery, or if you look at the indigenous peoples and look at the dispossession of land and the displacements and just the separation of children from family, and what that did to people and continues to do in terms of historical trauma, and how that shows up even in health status till this day. So you have that initial historical insult that has caused historical trauma that continues to be passed down and continues to show up even in health. Then you have structural barriers. What are structural barriers? So here we're talking about obstacles that pose a barrier to a people collectively. So something that is in place, it could be policy, it could be a process, it could be a system, but it gives advantage to some groups, but it is a barrier to other groups. And so we see that in the structures that we have in place, because some of the structures have been in place for so long. Who put the structures in place? Think about policies, for instance. Think about things like segregation. Till today, when you go into most places, you still continue to see that. It's not a law. There's no law that says, oh, all the people who are from this race ethnicity need to live in this place. But that is how it has been, and it continues to be perpetuated. I will tell you, here in Duluth that I live, around where I live, we're the only Black people that live here. On my streets, in the general location and general area, which will tell you something. I also know where I do research with the African American community here in Duluth, and I know where most of them live. So you still have that. And what happens with that? What are the resources that are available in those areas? Are they the same resources that are available in other areas? So that leads us to inaction in the face of need, because based on these structural barriers, you then have groups that have needs that others do not have. And what we continue to do in a lot of cases is to aim for equality versus equity. I know we talk a lot about this in public health, but we should really move away from just the words and it being a cliche to actually looking at how does that come about and what can we do about it. So you have things that, let's say it's the digital divide, for instance. So providing the same thing to everybody doesn't necessarily solve their problems or meet their needs. Some people have less need. And so giving the same thing to them that you're giving to people who have more need only gives them more advantage. And so we continue to see this. And then based on the structural barriers, whether it's policies that we have and other things going on, those begin to create societal norms. That's why we see higher incarceration, for instance, in certain groups. And then it begins to look like, oh, this group of people are more given to criminal intent, things like that. We begin to see those. You begin to see things like dropout rates that are higher with certain groups, and it becomes a societal norm. And we begin to imbibe it. Sometimes it shows up as implicit bias, and I'm going to talk a little bit more about that, talking about the personally mediated or individually mediated racism. But another thing that's of interest in terms of institutionalized racism, and this particularly I see a lot in the medical arena, in healthcare, is biological determinism. So this is a situation, and it shows up in other places, it's not just in health, but this is really the ideology that the traits that people have been passed down to them, and that at conception or at birth, that whatever you come out with, that determines your abilities, that determines your capabilities, how far you can go, what you can do. And so we see that play out. I see that play out in things like education. I see that play out in healthcare. So it's almost like, come on, if you're from this race ethnicity, then this is likely for you. As if just by being born with a certain color or skin color, that determines your trajectory and what happens to you based on that. So that is a shift that we need to have in public health. That's a shift that we need to have in every arena of life, really. We need to move away from that. So let me talk about how that plays out then in our day-to-day interactions, looking at individually. I have to click on the slide. Okay, so based on these things, because we the structural barriers that we see, they begin to develop, into societal norms, because you have these things perpetuated time and time again. By the time you see things like dropout rates constantly in a particular group of people, it shapes people's perceptions of that group of people. I will use education for an example. So I have kids that have gone and are going through the public education system. And so when people perceive a group of people in a certain way, implicit bias, the stereotypes, and that's where we begin to see that, because by default, we then interact with that group based on those societal norms, based on things that, we have seen about that group over and over and over again, without questioning what are the things that actually play into that. So using education, for instance, we know that generally, Black boys, over time have not been expected, they have very high dropout rates from high school. And so teachers don't push that hard either when it's a Black boy. It's almost like if they can just turn in their assignment, if they can, if they can get through, if they can just graduate. And these are kids that have much more potential to be much more. I was at a presentation last year, a couple of years ago. There's an American Indian doctor that we have here in Duluth, just does a fabulous job. And he said his teacher, when he was, going through high school, had said to him, trade school is what's good for you. No encouragement whatsoever, because they don't see that, and people don't come at it it's from a good place, in quote. But the thing about it is, with what has been institutionalized, with the societal norms that those have built, we have this implicit biases, and even when we have good intent, it still shows up, and we kind of, we're prejudiced in our assumptions, and then our actions become discriminatory. That's what we see. And so it can be intentional, it can be unintentional. Think about what happens. I'm Black. I know what that is like. The things that they are real. These are experiential. If you are not from a certain group, it will be lost on you because you don't see it. I can't tell you how many times that when people ask me, where do you work? And I say, College of Pharmacy. The next thing that they ask me is, are you a student? It's almost like a lot of people in their heads, and I'm not that young. I mean, I finished pharmacy school, like, I don't know, 20 something years ago. So, I mean, I know that people can go to school at an older age, but I keep thinking, why is the first instinct to ask whether I'm a student? Because for a lot of people, they can't even see that, can this person from this group be a professor? Can the person from this group be a healthcare provider? Because a lot of people have not even seen that, especially here where we live in the more rural areas. That's what obtains. Probably in the more metro areas, people are able to see that. So it shows up in our actions. It shows up in what we do and what we don't do. What opportunities also that we offer others. I was talking about education. I have two boys. One is, just finished his freshman year in college this year, and the second one is a junior in high school. And I think back to my discussions with teachers in teacher conferences and what that looks like and what they are willing to do in terms of, stimulating learning, or encouraging this person to be all that they think that the person can be. So sometimes it's missed opportunities that we see. So it's not just what we do, it's also what we don't do because of our perceptions of people from different groups. And then this then maintains the structural barriers that we have and continues to perpetuate the societal norms. Then we get to internalize racism. That is what it then does to people from groups that are discriminated against, okay? Because then a lot of people from these groups begin to see themselves in the light of how others have perceived them, other people from other groups perceive them. And so they also see limitations. They don't see a trajectory. They don't see the abilities that they have because they also feel that their abilities are limited. And what happens with that is they embrace a certain standard, and there's something about, it's called a phenomenon of embracing whiteness. I'll tell you a story. So I did this research with low-income African-American women looking at their patient satisfaction with healthcare, both as patients and as caregivers. And I remember one interview that I did. It was a lot of interviews, and this particular participant talked about how when she goes in to receive care, she says, I talk white. And I paused and I'm like, what does that mean? What does that mean? She said, I try to not speak as an African American with, the colloquialism and, the what accents and so on. So I try to enunciate in the way that a white person would. I try to, so that I can be considered intelligent, so that I can be considered educated, because I am. And she said, and people have told me you speak well. And I'm like, what does that even mean? And so you see someone who feels that, to be accepted, that the value that others place on her is how much she aligns with whiteness, which has become a standard. And so that's how she sees herself. And this is someone who is educated. And so we begin to see people who feel limited, and then these things are their lives begin to play out in a way that certainly reflects the values that society, the norms that society has created. And it does erode their sense of self-worth. it does erode the sense of self-worth. I see here, like I said, maybe in the more metro areas, that may not be as much the case because people are able to see, such diversity. But you will see that as we pull away from the more metro areas and we begin to come into the more rural areas, you have less diversity. And that's where, we begin to see more and more of these things. My children have gone through the educational system. They've never had a Black teacher. They receive care. They've never had a Black doctor. Their pediatrician has always been a white person. And so do they see themselves in those careers? Do they see themselves in those professions? Here on the Duluth campus, I'm the only Black faculty in the College of Pharmacy. I know what that means for the Black students that are in class, that they can come in and someone walks in who looks like them, but is a professor. It inspires them. And so I see myself as not just coming to give knowledge to people, but coming in just by being me and helping to shift something in the mindset of not just the Black students, but also the white students that are sitting there in class, that they can see that the color of your skin really does not determine your abilities or limit you in any way in terms of what you can achieve and who you can be. But that's what internalized racism does. That's what it does. It makes it very stressful when persons of racial ethnic groups that are in the minority enter into spaces. It causes a lot of anxiety. There's a lot of microaggressions. It's a stressor. I just want to put it that way. And like I said, it's very experiential. And that's when we begin to say that this is really a public health situation. It affects health, not just in terms of how people treat you. It affects health, even with people who are educated. There are times when you second guess yourself. There are times when you question because of how other people have treated you and where other people have placed you and the worth that they have attributed to you. And you have to work really hard to maintain a sense of self-worth because everything around you is not saying that. And then finally, it does undermine collective action because groups are not able to come together to say, okay, this is not okay and we need to do so. We're seeing more of that happen now. But when people are in preservation mode, when people are in survival mode, okay, that's not what they're thinking about. Advocacy. They're not thinking about, can we push for policy? And so you have few people that are able to do that kind of work from groups that are in the minority. So this is really very stressful, and it continues to limit how people move in society. So the race-associated differences really, these are really associations between socioeconomic status and race, because based on institutionalized racism, we continue to then see communities of color, populations of color being more in the lower socioeconomic status, and just historically, because they haven't had the same opportunities. When was it that, for instance, Blacks were allowed to vote? They haven't had the same opportunities for the length of time that, like the white population has had. And so you have that gap that has been there, but the issue is we still have structures that continue to maintain those gaps. And those are the things that we then need to deal with. So there is a strong association between socioeconomic status and race. And then you have a strong association between socioeconomic status and health. And that's why we talk a lot about the social determinants of health. But with the social determinants of health, what we really need to contend with is racism. With racism, there is that differential in power. Because institutionalized racism is about the differences in material resources, it's the differences in political power, in who has leverage, who is at the helm of affairs in different places. It's differential in access that people have and the self-efficacy that they have. If you look at, so I will use Duluth again as an example. So, I mean, Duluth is a small town. We have 2 high schools in Duluth. One high school, the 2 high schools, of course, they're in 2 different locations. One high school is in a location where it's more middle class and, higher income class. The other high school is in a location where it really serves a low income population. And you see the differences in the assets. We see the differences in the resources, not just in what is being provided to the school, but you know that there are resources and support from who has their children in those schools and what they're able to leverage. My son, who is a junior in high school, he plays on the varsity team for soccer. The parents leverage a lot of resources that have nothing to do with the schools because of who has their kids there. And so they are able to provide a lot of things, even from what they do themselves, you know, because they're middle class, upper class. And I think about I last year, my son just started driving last year. He turned 16 last year. And so I remember, and he turned 16 later in the year, so he wasn't able to actually drive till later in the year, and their soccer season had started. And so he still had to have either myself or his dad, you know, in the car with him because he hadn't gotten his license yet. And so we still had to take him. He would drive, but we still had to go with him for his practices. And most of his teammates had already turned 16. Some of them were 17 and they were all driving. And so it struck me one day that I got to dropping him off, and you have all these kids coming from practice, you know, on the varsity team, and most of them are juniors and seniors, and everybody's driving in a car. And I reflected, because I do work with the African American community here in Duluth, and so I'm also in their space a lot, and I know what that looks like. And I'm like, it seems like every player on this team has a car and can drive. I'm like, that is not the same everywhere else. That is absolutely not. These are people who they're having opportunities and exposures and assets that other people do not have. Because you can't even play high school sports unless you can bring yourself to school. So for the person who has to do the boss, how on earth are you going to be part of the team? Who is going to get you there? So you begin to see missed opportunities. You begin to see just that differential, even in exposures. And I know what just playing on a team does for people, the confidence that it builds, you know, the team dynamics that are there. They go to other places, you know, they travel, you know, to go and play. And so there is all of that. They see other things, and they begin to aspire to other things. And that is lacking for people who are not in that socioeconomic class. And those are mostly communities of color. And so you have all these differentials that put people on different trajectories that keep them then in that same, you know, socioeconomic stratum. And this continues to perpetuate the things that we see in health and in healthcare, because we see that they are very much related: where people live, what education that they have, the income level. Let's talk, for instance, about COVID-19. Who was much more at risk in terms of the type of jobs that people do? Of course, it's people who are in front-facing jobs, and those are jobs that are, you know, service-oriented. They are not jobs that you can do from your house. And so we begin to think about how that plays in continually, because, you know, of some of these differentials that we have based on race, ethnicity, that is associated with socioeconomic status, with structural barriers that people have. So this, of course, we begin to see in the differential in health and health outcomes. So what does that mean? Let's go to solutions. You know, I believe that as public health practitioners, some of the things, I actually think probably I'm preaching to the choir, but let's talk about it, because when we talk about it, you know, we bring it to the fore, and, you know, and we want to do something about it. What are the implications for public health practice? So first of all, I'm going to start with, you know, some of us that are in research or in the medical field, you know, where we're collecting data, even if it's for treatment and all of that. We need to acknowledge and utilize race as a social construct. There has to be that shift. There has to be that shift. There has to be that shift because it affects how we provide treatment. I have a friend who was telling me the other day, she went in to get a physical, and they had moved from one place to another. So it was like a new place where she was receiving treatment. She went in to do a physical. And so the healthcare provider who was taking down her information was, taking down her history, medical history. And so was asking her if she had any family history of this, that, and for most of the things that were listed, and we know the things that are usually listed, you have cardiovascular, diabetes, and so on and so forth. So she said no. The next thing that this individual says to her is, come on, you're Black. There has to be something. I said, a healthcare provider said that to you. She was absolutely. You're Black, there has to be something. So you see how just by default, and she wasn't saying it, she was just like, I mean, if you're Black, we usually see this, we usually see that. And so it's become a link. It's almost like race is linked to disease. If you're Black, or if you're Native American, or if you're, of any, there are things that are immediately associated with you, okay? So that is not okay. We need to utilize race as a social construct. So we have to, even in terms of how we look at data and how we look at findings from whatever, we have to properly contextualize the race relationship that we see, with the outcomes or with whatever it was that it was being associated with. We have to learn to question assumptions and to further investigate these race-associated differences that we see. If you did, if it was an assessment, a health assessment of an area, and you find that there are differences in race, you probably need to dig deeper and ask, okay, this racial group, where are most of them? What's the education level? What's the income level? What types of job do they do? What are other things that actually explain some of this differences? Where do they receive care? Who are they receiving care from? What kind of coverage do they have? We have to think about some of these things. So we have to then reflect on the inequities that might be playing into this thing so that we get a clue on what the problem is, so that we don't continue to address the issues as a disease that's related to race, but we begin to then look at structural things that we need to pay attention to. For example, with COVID, where I am, we could see that once we moved vaccination sites to community spaces, you had more people getting vaccinated. And so you had a barrier of access being removed. And so people are able to get to this. If you put a clinic hours at a certain time, who are the people that do jobs that are in shifts that are not able to get to the clinic for something, for testing or for vaccination? If you put it, always have it at hours where people don't have access to it, that's a barrier. And so sometimes when we say, oh, there's less vaccination rate in this group versus that group, what's the problem? Let's think about it. Let's question it. What are some inequities that might be playing into that? So we also need to acknowledge and, where possible, account for the associations between race and socioeconomic status. There are other things that play into this. I've talked about employment type. What are the neighborhood characteristics? Is it a food desert that's playing into this? What access do people have in terms of transportation? What's, the education level or access that they have to educational resources where they live? And then we also need to account for the within group diversity in these racial categories. I see that a lot, and I tend to, when I do research, I look at the African immigrant population differently from the African American population because we have different cultures, different historical contexts. I'll give you example here in Duluth. All the Africans that I know are professionals because they are people who came to the US pursuing education, for instance. So most of them are either professors in the schools around or they're in the healthcare system. Because, and that's a selection bias, because it doesn't mean that where they're coming from that you don't have people who are of lower socioeconomic status, but those are people who are able to come to the US because of the efficacy they already have. And so you would see that even within that group, within Blacks, that you have people who have more advantage or people who have more self-efficacy, and we have to be able to. And then you have racial groups where you have so many different groups. Look at the Asian American group. When we say Asian, there's so many groups in there. with so many different contexts, culturally, historically, language-wise. And so what sometimes might even make more sense will be country of origin and ancestry. That's what makes more sense, even in medical and in research. That is even what might make more sense in terms of differences. So what's the charge? We need to acknowledge the existence and the impact of racism on health. And so more recently, there's been a push to actually develop some explicit measures so we can see what the impact that racism, institutionalized, the personally mediated racism, internalized racism, what's its contribution to the differences that we see? Because it does contribute, but are we able to measure it? And so we have researchers that are working on that. And if you're interested, maybe it might be something that might be of interest to you to also work on. We have to challenge and change the structures and the systems that continue to perpetuate these differences that we see, and encourage, some of the discrimination that we have, especially in healthcare and generally in public health. So I want to just charge us, wherever it is that you're working, look at what the policies are, the processes, the practices that you have in place. Do they advantage some people and disadvantage other groups? We have to think about it. And it doesn't matter where you're working. I think about it even in terms of where I teach. Thinking about even things like admissions, the admission process that we have, does it give advantage to some people and disadvantage to others? Do we have criteria that continues to systematically take some people out of the pool? That is structural. That is structural, and that will need to change. So we have to examine our policies. We have to examine our processes. It's not about one size fits all, because everybody doesn't have the same need, and people have different contexts and historically different things that have put them in a certain place. And we have to be able to account for those things. So we have to, another thing that I'm very passionate about, and I really believe that this will be helpful. I've talked to you about just being visible as a Black professor in a class where it's majority white students, and what that does for the students, especially the Black students. We have to increase representation in health, whether it's public health, whether it's medical practice, in research, in academia, in all the different professions, but focusing on health because that's where all of us are focused on. There has to be more representation. There has to be more representation. It helps people to then knock off those limitations in terms of the internalized racism, and aspire to be more. And when they're more, they bring a perspective that others do not have. I was in a meeting with a colleague. He is Black too, and he's in the medical school. And we are at this meeting where we had all this different healthcare agencies working on something that is supposed to be addressing social determinants. And it's something that it's with an app, and so on and so forth. And the first thing that jumped to us, which we could clearly see, is there's a digital divide. How are people who don't have, is this, so the first thing we're asking is this accessible on the phone, this platform that you have built? Because we know who we work with, we know where we come from, and so we know what the problems can be. And that's what happens when you have diversity. People are able to bring different perspectives because if you're not from this group, you can't see what they see. There's an African proverb that says that the stranger only sees what he knows. And that is true. There's some things that will be totally out of your view. You would have blind spots because that's just not something you have encountered experientially. It's not something that you know about. But someone else who is from another group, being there brings a perspective that can change a policy or can shape a policy to be more equitable. And then we have to have just more community engaged practice, whether it's in research, whether it's in health promotion, whether it's in the interventions that we do, or in the healthcare. We have to engage community because community knows what works for community. And I've seen it with COVID, for instance. There are things that the community-based organizations that I work with have done that healthcare system will never have been able to pull off if they didn't work with community, because they were able to bring, they had community outreach coordinators who grew up here and who were reaching out to people that they have known all their lives. And that's how they got them, to get vaccinated, helping them to navigate, the digital world, especially for those who are much older, because they are elders to them, but these are people that they know. And so they could actually call them up on the phone and talk them through the whole thing, actually register them. And if they need to be brought to the site, they'll go and bring them. That's very culturally responsive. And so we have to consider that more engaged practice, and it helps. It helps with some of our processes. This community outreach coordinators would actually be at the sites. And so when you have community members come, you don't have that issue of, so much. You have more trust, let me put it that way. Because you see that, of course, because of historical events, for instance, that communities of color are more skeptical about, not just historical events, I would say even more so with contemporary experiences that they have had in healthcare. But coming there and seeing someone who is from the community there, who can advocate for them, that makes it so much more easier, and they're more willing to engage and receive healthcare. And so we'll see less disparities in that case. So one more thing I just wanted to post was, should we continue to document and use race data? That's a question that people have, like, okay, so what's this about race? My take is yes, we should, because that tells us whether we have moved or not. But what we need to consider when we document race is, why is race being documented? For some things, it's totally not relevant and we don't need that. We did some research around COVID needs assessment, and I remember one of the community members saying they went to get, it was something financial. They had a peer who applied for the same thing. Both of them work in the same place, do the same type of job, have the similar income level. His colleague got, he was denied. And he felt like if they did not have race on the form, it's like, what has the race ethnicity got to do with my getting this, or not getting it? So maybe we should think again about what is the relevance of race, and what is the importance in whatever it is that we're doing. If we're documenting it, why are we documenting it? Is it just going to elicit some implicit biases? How is it measured? How is it collected? I've talked about how you have differences even within groups. And so we need to think about it. And then we need to think about, if we're collecting race, what other measures are we collecting, so that we can appropriately contextualize and be able to explain differences. And then we need to think about context, because race often intersects with other identities that are not racial. And so we have to think about that. And the time too, I would say, for instance, what race means, right? And it keeps changing, with events. And so we need to think about how that is too. In this recent year, a lot has happened around race, and how we're thinking about it is probably different from how we were thinking about it 2 years ago. So finally, I just want to say to us, it's difficult, it can be uncomfortable, but the one thing that we really need to continue to do about racism is talking about it. Talk about it. Let's talk about it, because if we don't talk about it, we will not do anything about it. So let's keep talking about it. Let's keep questioning. Let's keep looking at our processes. Let's keep looking at our policies. Let's keep introspecting and asking ourselves, are we adding to racism? And then what can we do even as individuals? But the key thing is really, can we change things even structurally? Because that's how public health works. We need to change policies. We need to address structures. And we need to put things in place or change things so that we can have different outcomes. Thank you.
Well, thank you very much, Dr. Okoro. I've observed your work over the years, and it's a privilege to have you presenting here at the Dakota Conference. My name is Mark Strand. I apologize that I had been firewalled at the beginning, so wasn't able to introduce the presentation. So happy to be able to wrap it up here at the end. I'd like to invite any of our attendees. We've got time to post their questions in the chat if you would like. Since there are none posted in the chat presently, I'll begin with the question. It seems as if some people in our country are getting tired of the word racism, and they're considering it to be like, oh, anything is racism. And do you have any thoughts on whether there's a way, or, is it the fact that it's overused and therefore loses its meaning? Or is it that that's actually just a guard and that the issue is just as deep, and those who don't want the word are actually frustrated because they don't want to have to admit it? Any thoughts on that? Because I'm hearing a lot of people saying, well, yeah, if I'm not happy, then it's racism. Can you respond to some of the negative kickback we're getting from some sectors of society?
Well, thanks for that question. I think it's both. I do agree it's not racism, and sometimes maybe we attribute some things to that, but we can't then shy away from it, because it triggers people. That's what I know. It does trigger people, and I think again too is because when we say race, people immediately think about the individual. And so race is almost like I'm saying you're being racist, but there are structures that we work within that perpetuate racism. So it's not necessarily the one-on-one. The one-on-one is not necessarily, and so I think that's what we need to do. We need to really think structurally. We need to think so that it's not a blame game. I think it's how we posture it that sometimes is a problem. It's not a blame game. It's what do we have structurally, because it starts with that structure, the structures that are in place that have created the societal norms. And if those change, hopefully over time, other things will change. But we absolutely have to talk about it. I don't know what else that we're going to call it. We don't want to whitewash it, it is what it is. Anything that systematically, gives advantage to one group and disadvantages another group, it is racism. It's some type of racial discrimination. And that's what it is.
Thank you. We have a question in the chat. It says, it should be noted that the January 2021 issue of the Nation's Health had an article discussing that we as a public health organization should make a resolution on racism, and the Wisconsin Public Health apparently did so. I guess maybe that's not so much a question as a comment. Do you support that kind of thing? And then the follow-up is, could the North Dakota Public Health Association consider this? Do you have any thoughts on that or advice on that?
Yeah, it's one thing to make a resolution. That's fine, but we also want to see that being put into action. Yeah, taking a stand is fine, because it says, okay, we agree that there is an issue. I think that acknowledgement is so important, to say, yes, this is a problem. Because that's why, because if you don't even acknowledge it, you're not going to do anything. So to be able to take a stand and to say, yes, this is it, and we will not tolerate it. But then you then have to then go to, what then do we do to dismantle it? Because it exists, but it then needs to be addressed. How do you dismantle that? And I often see that that's where, sometimes we have a problem. We have people who have dedicated resources to it, but what exactly are we doing? What exactly do we need to do? That's why we need to all come together and talk about it. Because like I said, some things you may agree, yeah, this is not okay, but you can't see the full picture because it might not be your experience. And so you need other people, and talking together will help.
We have another question. Kia Ismail, who is the student president of the NDSU Public Health Association, has posed a question. As healthcare professionals, what are some immediate steps we can start to take reducing racism in our community?
I would say, for instance, just getting into the community to understand different groups. I feel like in healthcare, we're kind of siloed in facilities, and it's a space. It's the clinical space, and you have people come into that space. We're not able to see the context of their lives in the clinic. And so what I would say in terms of medical, it makes such a difference when you're able to engage with groups in their space and be the learner, and just observe and have them talk with them, ask questions, but you have to do that in their space. You have to do that in their space. This is June, for instance. It's going to be Juneteenth. A lot of healthcare providers have no idea what Juneteenth is, but that is so important for the African-American community. And if you're someone who is in healthcare, there's so many things that are going to be happening that will impact health, nutrition, and so on and so forth. But we're totally lost on some of these things. So I would say those are some of the things, talking with the community to see even how your structures and your processes impact them, your healthcare processes. Yeah. how it does impact the group.
You're getting lots of chats saying great presentation and everything. I have, yes, this week, I don't see any other questions in the chat right now. If anybody has a question, please post it. This week, Fargo made the, I think, important move. The City Commission has hired a new Director of Diversity, Equity, and Inclusion for our city, Dr. Terry Hogan. And so I'm excited about them putting their money and putting their action in place there. But one of the city commissioners, I heard him last night at the city commission meeting, said, well, this is ridiculous. Well, of course he's going to find racism. We hired him to find racism. So the fact is his title is all positive affirmations, diversity, equity, and inclusion. But yet this one city commissioner insisted on saying that he's being hired to find racism. Any comment on this? Because I think they were trying to do what I was suggesting in the first question. We're not hiring an anti-racism director. We're hiring somebody who makes Fargo a city that's inclusive and welcoming and of all diversity. But yet the conversation was forced into this. Well, of course he's going to find racism or else he won't have a job. Any comments on how to speak to these in a public forums? Because I was so exasperated listening to the conversation.
Yeah, I mean, it's something we need to have conversation about, because it's difficult to kind of address like in a public forum like that. Like, I mean, how do you even engage with this individual, you know, in that kind of public arena? But I feel like we should create spaces where we actually sit down and just have very candid conversation. How do you feel about this? What do you think and why? And we really ought to put those types of positions are actually solution oriented. They're not coming to find something, like you said, they're coming to create something that then addresses what is. And so, yeah, and that's how it is. It's unfortunate if people are not able to see that, because what they're doing is they're coming to create something. They're coming to address something, or maybe, you know, dismantle something, and that's the posture. But I feel like conversation is good. If we can sit down and talk, you find that, you know, you may have differences, but if you can actually sit down and have some candid conversation with people, you know, that might be helpful. Yeah.
One of the individuals says, as an African, how do we reconcile the shared racial discrimination we experience? That person is an African student. How do we the shared racial discrimination we experience with the African-American community, but that's different from the historical background? Our time is almost up, but I think that's an important question. If you could give a quick response, how do we distinguish? She was wondering, how does she distinguish as an African immigrant who didn't have the sort of slavery history past?
Yeah, so what you have to contend with is that the person who is discriminating against you doesn't understand that and doesn't know that, really. Yeah, so for them, you know, and it depends. Sometimes the discrimination is because you're from outside the US. It may not necessarily be just race. So that's why I said there's intersectionality. So you have that country of origin, because there are people that will discriminate against you because they feel like maybe you came to take something away from them because you're from a different country. So there is intersectionality. So we have to understand that. In terms of just being Black yourself, but of course, just like you can see, you're a student, you know, you're on track to become a professional. You have some efficacy, you have some leverage. So you have to acknowledge the privilege that you have and then be able to leverage it for the common good of the Black population. That's what I would say to you. That's something that I have done. I feel like, okay, if I'm in a position, yes, I'm Black, I'm experiencing the same thing with you, but I have some privilege that most other people do not have. And so what you want to begin to think about is how you can use your own privilege. I have a voice, I can speak in places where most other people will not be able to. So I can be the voice that can advocate, not just for myself, but for Blacks in general, regardless of and they're trying to also understand the historical context is very key, because you don't have that context. But if you can understand a little bit of the context, you know, for the African American, because it's different. You know, that context of slavery, very different. So understanding that you can empathize. It's not your history, but you can see how it's affecting them, and that helps.
Dr. Okoro, thank you so much for joining the Dakota Conference. I'm sorry we're not together here in North Dakota, but maybe next year.